will take us through this, webinar. So without further ado, I would like to invite Dr. Lucy Mungai to begin to share her screen. Dr. Lucy Mungai is a pediatric endocrinologist working at Kenyatta Hospital, and she has vast experience in the management of type 1 diabetes. So I'll stop sharing my screen and let Dr. Mungai take the floor. Thank you so much for joining. If you have any questions as we go along, kindly use the chat to send us your questions, and then we shall be able to review the questions as the meeting progresses during the question and answer session at the end. Thank you so much for your attention and welcome. Dr. Mungai, over to you. Doc, you're on mute.
You can hear me now?
Yes, that's clear.
Diabetes, and this is the lineup we have for today. You go through definition, pathogenesis, clinical presentation, treatment, and the emergencies that we might encounter with these children. The thing is that this presentation is just maybe to let you know what is there in type 1 diabetes. There has to be another one that will come later on so that you can understand fully about type 1 diabetes. We can't really deal with the type 1 diabetes in 20 minutes. So in the definition of type 1 diabetes is a condition that is found in children where they don't have any insulin. They are not making any insulin in their body. And when you check their blood sugar, you find that the blood sugar is equal or more than 11.1 millimoles per liter. These children normally have their classical symptoms of increasing polyuria, polydipsia, their weight loss, and majority of the time is within 2 to 6 weeks. But we have atypical cases where this patient can present within days, and they come in with DKA or diabetic ketoacidosis and might come in coma. And many other conditions can be diagnosed, and the diagnosis of diabetes can be missed. In other cases, we can have the slow onset where they may come several months after, and they can come walking, and the mother can tell you the child has been drinking water maybe for the last 4 months. But sometimes they might come in shock and become in shock, sometimes even in coma. Normally, we don't do OGTT in patients with type 1 diabetes. HbA1c may help to make the diagnosis to know for how long they have been having the condition. But it's not always that if you don't have HbA1c, you can make a diagnosis of type 1 diabetes. We also do antibodies against the anti-GAD antibody, isolated cell antibodies, but it's not compulsory for you to do them to make a diagnosis of type 1 diabetes. We also check the C-peptide levels to tell us how much insulin they are making, but it's not important at the time of the diagnosis. If you look at the epidemiology of type 1 diabetes, you can look at the areas that you can see the dark areas. You can see my cursor, where you can see in Canada, we have Australia there on the other side of the world, and then we have the Nordic countries here. And the highest, what they are telling us is these are countries with the highest of type 1 diabetes. And the highest we find in Finland, where they have in every 100 children, 100,000 children, in every 100,000 children, we get new cases of type 1 diabetes. That is in Finland. They have the highest in the world. Back home in Africa, we have Sudan here. We have Sudan and Southern Sudan together there. We have Egypt, we have the Morocco, Algeria, Libya, and then we have Tanzania, which is our neighbor. We haven't done any studies in how the prevalence and the incidence of type 1 diabetes. And you can see Tanzania, they are recording patients, less than 4 children in every 100,000 less than 4 4 children in every 100,000 new, that is we have less than 4 cases in every 100,000 children per year. And this is the steps that are followed up to get type 1 diabetes. You can see between A and B, these are normal patients, but they have genetic predisposition to get type 1 diabetes. And then we have the precipitating factor here. We don't know what it is. Sometimes it might be a virus, it might be an agent, something that an antigen that they have ingested. And then with that, we have the damage of the beta cells, and progressively becomes worse with the time. By the time the patients are presenting, they usually have about 70 to 80% of their beta cells are already damaged by the time they are presenting with the symptoms. So when they come to us, they have maybe about 20 to 30% of their beta cells. And with the time, it will progressively become, and they have no C-peptide levels, they have no insulin at all that is being produced in their circulation. I wanted to go through these houses. It's a simple way, we call them the stories of type 1 diabetes. You can see this is a normal person before a child gets diabetes. We have the door there, we have the fireplace there, and we have the firewood. And the firewood in this case, we take it is the glucose that patients, when you take the carbohydrate, they are all digested and they become glucose, and then it's taken through the door. And you can see the house is warm, and in case of a person or a child, the child is feeling healthy because they have energy to do what they need. And then in this case, this is the clinical presentation of this patient. Now the firewood has been left out in the capillaries. There is no glucose going inside because the doors are all closed, because the patient doesn't have any insulin, as because the doors are all been closed, and you need the insulin to come and open these doors. And without insulin, the glucose remains out. And at this level, the blood becomes very thick. And when the blood becomes very thick, what happens, there are sensors at the level of the neck that usually they send the signal, and they say what you call the osmolarity of the blood is very high. And then the kidneys are directed to try as much as possible to get rid of the glucose. So the patient will now present with the polyuria, passing urine several times. As they pass urine several times, then they become dehydrated. Then they get polydipsia. So with this, because they have no glucose within them, they are now also very weak during this time. And as the body becomes very weak without any glucose, the body has to get another source of glucose, another source of energy instead of glucose. And in this case, what the body does is to burn fat inside the cells. And as the fat is being broken down, we have the release of the ketones body, which comes as the black smoke that you see here. And then the ketones now are deposited at the level of the blood. And then this now makes the blood acidic. So the patient has diabetes, the blood is acidic, and you say that patient has diabetic ketoacidosis. At this level now, because the pH has gone down, and the patient, the blood has become acidotic. The sensors also at the level of the baroreceptors, they usually send the signal to the brain. And then when the signal is sent to the brain, what happens is that the lungs are told you have to get the pH back to normal. So the patient will present now with deep breathing, and the patient now at this level can be mistaken for any other condition. The patient was weak before, had polyuria, polydipsia. In this case, now they start getting Kussmaul breathing. They have deep acidotic breathing, and when they come, majority of those small kids, that they can be misdiagnosed and be said to have pneumonia. In this kind of time of coronavirus, because several times people thinking that DKA patients have corona patients. But just need to do a blood sugar. So for every patient who comes to any center, this patient, what they require is just a blood sugar to make a diagnosis. And then, so this patient, this is a diagram, this is a one-day diagram, try to explain, to simplify how the diabetes present with the passing urine several times. They have lost weight because of the fat being broken down. They have no energy because the cells can't work at their maximum level, because the glucose is toxic to all the blood cells. Also, the pH is low, it's acidotic, so the cells can't function properly. Then they are taking a lot of water, and they are replacing the urine they are passing with plain water. Remember, when the pH is low, also the potassium that is usually inside the cells is released into the peripheral circulation. So as they are passing a lot of urine, they also lose potassium in the blood, in the urine. This is a child who was 7 months by the time they presented, came in with wasting, had florid candidiasis, was wasted, hair changes, and came in with chest syndrome. So a diagnosis of pneumonia was made, and with malnutrition. And you know, in our setup, the first step, there are 10 steps in management of malnutrition. So what was they treated the patient for malnutrition, and the first step is giving the patient glucose. So the child was given glucose, but a few minutes later the patient went into coma. But they wanted to check whether they had given enough glucose, so they checked the blood sugar, and the blood sugar was 39 millimoles. At that time, the diagnosis for pneumonia or type 1 diabetes was made. So the thing is not going. So the management of diabetes at this time, when you get the patient at this level, sorry for that, my computer is refused to move. Okay, this is a video clip of a child who presented in DKA, and you can see exactly what I'm explaining. The patient is dehydrated. The patient, actually, this patient was semi-comatose, and you can see the patient, the dehydration in diabetes actually usually hides itself because of the high glucose they have with the circulation. They tend to retain a bit of the interaction because of the glucose. The patient is fluid at the top. The first thing that they are given the fluid. And remember, this fluid is a killer. It can kill a patient by rehydrating the patient. You have to know how the fluids are given. They are given over 48 hours and given very, very slowly, because you can't give them the fluid like a patient with diarrhea and vomiting. If you give that, the patient will get cerebral edema, and the patient can die from cerebral edema. Mortality from cerebral edema is between 24 to 100%. They also require potassium chloride to replace the potassium that they have lost. And they also require the key, and the key for this time for opening the door is the insulin that they require, so that they can open the door, so that the glucose can go inside. And when the glucose goes inside, then they stop breaking the fat, and then they stop the ketones from forming. At this level, the patient is not supposed to eat anything. They're supposed to be nilled by mouth until all the ketones have gone out of the circulation, meaning the patient has gotten the glucose to go inside the cell. And as I'm this is to explaining about DKA management. I need another 3 hours for you so that I can explain how we manage small babies with DKA. I don't think I can dwell with it at this time. The only thing you have to know at this level, the insulin is given every hour. The insulin is given every hour, and you have to check the blood sugar every hour. And you have to check your potassium, and you have to check your potassium, the ketones, every hour, every 4 hours. So you do your BGS, you check your potassium every 4 hours, and check the blood sugar every hour, and give the insulin every hour. When the patient has come out of DKA, then you have to put the patient on maintenance insulin, because now the patient doesn't have any insulin, especially the small babies. What happened is that in a normal person, this is the diagram explaining in a normal person what happens. And you can see during breakfast how much the glucose, the blood sugar, the insulin is produced in the morning. Because in the morning, normally children have growth hormone, they have cortisol, they have a lot of hormones, adrenaline in the morning that actually inhibit the function of the insulin. So the insulin, the patient produces a lot of insulin in the morning. Lunchtime, they produce a bit more. And then we have also at dinner time, they have the insulin. But you can see all through the time, they still have some insulin. There is never time that they don't have any insulin in the circulation. So what happens is that at this time, you can see that in between when they are not feeding, the body produces glucose. And what happens is that the liver makes insulin, makes glucose, and the body produces insulin to take care of that glucose that has been produced at the level of the liver. You can stay the whole day without eating, but the body will produce glucose at the level of the liver. So this is what you call the basal insulin to take care of the patient when they are not feeding. And then we have the bolus insulin that is given when the patient has fed. And then these are all the type of insulin that are available in the market currently here in Kenya. So we have the oldest insulin that all of us we know NPH, and I don't know whether we know it as a separate insulin because it is known as either insulatard or humirin N as the NPH. And then we have the humirin R, soluble insulin or regular insulin or actrapid. This is the same one and the same insulin. Then we have here Humalog, Novorapid, and Apidra. They all work the same. And then we have down here, we have the basal, what you can call the basal, we have Revemil. Revemil is one of the other insulin that has been produced to take care of the time the patient has not fed, but it has a bit of a peak. And then we have the Lantus here, which usually takes care of the patient for about 24 hours. So this is what we usually do when you are trying to give the patient, we are trying to replace the insulin. So we have to see how to imitate how the body in a normal person, how the insulin the body produces insulin. So you have the basal, and here you can give Lantus or you can give Detamil. Detamil is supposed to be given twice a day. So if you are giving Detamil and you're giving the other insulin, the patient will be on 5 injections. If you're giving Lantus, the patient will be on 4 injections. What we have been doing currently is because we have found that it is cheap to give, instead of giving Aspart, Lispro, or Glycin, what we have been doing is to give the patient soluble insulin or Actrapid or Humirin. They are one and the same thing, which will cost cheaper for the patient, especially the patient who are coming to the public hospital. It will cost between 200 and 500 shillings. And they have insulin in a vial which has 1,000 units, and the patient can take it between 2 and 3 months. Then we have Lantus. Now the price has come down. I've realized for our patient, they are able to get it about 1,000 and maybe 1,100. And it's able to take a child for about 2 to 3 months. So and if you give it in the vial, it has been working very well, especially for the poor patients that I deal with in the Kenyatta hospital. But if you have patients from the periphery, who can afford, all of them prefer the pen. What are the side effects of the insulin when you have this patient? The insulin actually is, the therapeutic margin for insulin is very, very narrow. Meaning, if you go too low, the blood sugar will go up. If you go too high, the patient will have hypoglycemia. And most of the time when you give, if you see the patient, before they go into hypoglycemia, what they will present with, getting hungry all the time. So the mother will say the child is stealing food. So if you have a child who is stealing food all the time and getting hungry, that is not, and actually at that time, the blood sugar.
Dr. I think you're
the
on
temptation
mute.
or the temptation. Hear me now?
Yes.
Okay, the temptation at this time is to the temptation at this time actually is to increase the dose of insulin when the patient is stealing food and they're getting hungry and the blood sugars are high. So the blood sugar is high and the patient is stealing food all the time. Always try to go down on the dose of insulin. Otherwise, the patient will go into hypoglycemia. And if it occurs at night, it can be dangerous to the child. So these are the other little signs of hypoglycemia. The patient might become very angry and they see a child who is always crying and throwing herself or himself on the floor, may start having staggering gait. They are crying, confused. If they are writing, if they are in the class and they are writing, they will find actually they are writing straight lines instead of taking their notes in the class. So these are the way to manage the hypoglycemia. I don't know from the gadgets whether you are able to see. These are the different steps that you manage to manage the hypoglycemia. The thing is, you have to know hypoglycemia. I've given it in milligrams here. But if you divide 70 by 18, it gives you something like 3.9 millimoles. Anybody with blood sugar of 3.9 millimoles and below, we say they have hypoglycemia. And there are the different levels of hypoglycemia. For the small children, the small ones who are, especially the ones who are below 2 years, you can start them when they have hypoglycemia with a teaspoon of glucose, and then they don't eat anything so that you leave the stomach empty to get so that the walls can absorb the glucose very well. If you give them food that time, then the wall will be covered. So you don't give them anything for 15 minutes, then 15 minutes you repeat the blood sugar. If you find it's still below, then you can give you can repeat the glucose. And if you give 2 to 3 times and you see and it's not improved, then you can give glucagon. At the moment, we don't have glucagon because at the beginning we used to have give every child glucagon to carry in their bag, but they all expired in their bag because they never used them because they used to use the glucose and the glucose worked. So how long can a type 1 diabetes patient live? We have our lady here. Gladys was diagnosed to have diabetes at the age of 7 in 1924. And we know that the first child to be treated, the insulin was discovered in 1921 and 22, the first patient was treated. So for Gladys, whose parents had died during an epidemic of meningitis and adopted by a neighbor, she managed to live from Gladys managed to live from the 1924, and she was able to live until she was 93 years of age with type 1 diabetes. So it is important that we know how to manage the diabetes. And I will repeat as I'm ending, because I have just 2 more slides to go, that diabetes does not kill. It's important we know that diabetes does not kill. What kills a patient is complications of diabetes. This is our lady, Sonia Sotomayor, who is a Supreme Court judge in US currently. She was diagnosed with diabetic at the age of 8 years. Her mother was suffering from depression and her father was a drunkard. And they traveled from South America to come to US. And she managed to go through law and ended up being a Supreme Court judge with type 1 diabetes. That diabetes does not stop anybody from being what they want. Currently, we have our patients. We have at the moment we have 3 doctors now who are graduated from the clinic, and they have qualified. One of them is coming to do masters in surgery with type 1 diabetes. We have one of our colleagues, all of us, we know him, who is going to be about 50 years and has been having diabetes since the age of 8 years. So we have hope in diabetes. This is our 7-month baby, and 3 months later, you can see this baby, how the baby looks like. So it doesn't mean that when a child has diabetes, the death certificate has been signed. We have a lot of hope for our patients. And with that, I can only tell you diabetes does not kill, but complication can kill. Why do patients develop complication? 1, if the patient is not following the instruction of the doctor. 2, if the clinician does not know how to advise the patient. 3, if the patient does not have the means, does not have the finances to take care of the diabetes, or they are not capable of managing their diabetes. And that I say thank you.
Thank you. Thank you so much, Dr. Lucy Mungai, for trying very hard within 20 minutes to take us through type 1 diabetes. I believe everybody has appreciated that we know how to diagnose type 1 diabetes. We know how to treat type 1 diabetes. And thank you so much for sharing success stories of patients who have done well after being managed properly with type 1 diabetes. So now I'll ask Dr. Ndede to start to share his screen. And I would like to tell everybody, if you have a question, we have the Q&A part on your screen. You can see the Q&A part of the screen. Kindly go there, post your question, and we'll be happy to answer it. So thank you so much. So our next presentation is on the progressive nature of type 2 diabetes, treatment inertia, and treatment guidelines. We have our consultant physician, Dr. Kevin Ndede, who who will take us through this presentation. Thank you so much, Daktari. Welcome.
Thank you very much, Yvonne. As usual, delighted to be part of the panel here on this very important topic of diabetes. And just as my senior has spoken, she was my teacher. Diabetes is a subject that requires a lot of time to discuss, but within the time we have, we will try and make good use of the knowledge that we can pass on this subject. So my allocated topic this time around was to discuss the progressive nature of type 2 diabetes mellitus, to look at treatment inertia, and also look at treatment guidelines, both locally and internationally. So just by way of beginning, we know that generally before we make a diagnosis of diabetes, then there's usually has been about 4 to 7 years of intermediate hyperglycemia, or what is generally called impaired glucose tolerance. The other common term for this is pre-diabetes. So by the time someone has this diagnosis of diabetes, then they already have had a long period where their sugar control has been poor. Now, the alterations in the biochemical milieu of these patients occurs at several levels. So if we begin with the pancreas, we can see the graphs over here. On the x-axis is the time axis, and on the y-axis, we could say is the value of the various parameters. So if we begin with the beta cell function, and Dr. Mungai has ably talked about this in type 1, we see the same in type 2 diabetes, that there's a linear correlation between time and the decline in beta cell function. And this generally occurs even in people who do not have diabetes. It is just that the rate is lower in those people. But when people are diagnosed with diabetes, then the rate of this decline actually increases, and progressively over the years, beta cell function declines. And we shall see later on that when it comes to intensification of treatment, if we extrapolate this line probably to the base, you will realize we get to a point where there is virtually non-existent beta cell function. And therefore, it means that people with type 2 diabetes will eventually, if they live long enough, require insulin therapy. Then the insulin levels, which appears here in blue, we can also see that from the time of diagnosis of diabetes, the insulin levels begin to decline. And this is incongruent with the decline in beta cell function. As a result, we also find that we get insulin resistance, so that even if you have sufficient amounts of insulin, the tissues that are supposed to utilize this insulin, particularly the liver, the adipose tissue, and skeletal muscles, they are unable to take up the insulin because of this aspect of insulin resistance. The other thing that changes is the incretin effect. We generally know that when we eat in the postprandial state, the gut produces some hormones, GIP and GLP. All these hormones are generally insulin secretagogues, and we see they begin to decline as well in the pre-diabetic era, as well as after the diagnosis of diabetes. What else happens? We look at the biochemical composition of plasma in the diabetic state. And what happens is that when you look at the fasting plasma glucose, that generally continues to rise. Of course, this is for people who are not adequately managed. And then the postprandial glucose also will begin to increase. So both aspects have actually been linked with a rise with progression of diabetes, and they also correlate with complications in patients with type 2 diabetes. So this is what I have alluded to in the previous statement, that soon as we get a diagnosis of diabetes, just like in type 1, complications can happen, and they are both microvascular and macrovascular. These generally tend to correlate with the duration of diabetes and the nature of the glycemic control. So what are some of the factors that predict progression of type 2 diabetes? So the clinical predictors of disease progression and medication initiation in patients with type 2 diabetes are generally these ones. So younger age at onset, weight gain, and a higher baseline HbA1c. So most individuals are likely to be initiated on medication if they have these aspects. And also, these are predictors of clinical progression of disease. Now, there's this study that was done to look at the progressive nature of type 2 diabetes, even among individuals who are initiated on treatment. So these were all patients who were initiated on monotherapy with either rosiglitazone, since out of clinical use currently, metformin, and glyburide. So if you look at the graphs, you can see generally that over time, there are quite a number of patients in each of the treatment arms that failed the therapy. And the highest was with glyburide, followed by metformin, and rosiglitazone tended to do the best. So generally, even for patients who are on treatment, and this point underscores the progressive nature of type 2 diabetes, that over time, you will require more and more additional drugs for you to be able to maintain glycemic control. And this tells us that generally the beta cell function continues to deteriorate. So then moving on to treatment inertia. So the illustration here is to just tell us about the physical principle of inertia. So we have two buckets here. One is fully loaded with sand, the other one is empty. If you try to push either of the buckets, you will find that one is more difficult to push. And the whole idea is that because of the mass in the bucket, it becomes harder to push. And so clinically, we also have an aspect of treatment inertia, which in lay terms, you would say is the difficulty we clinicians or patients have in initiating treatment or intensifying treatment. And that is what we are going to look at next. So then there's this data that was published concerning the treatment inertia, especially as concerns insulin. So these are patients who had their HbA1c way above 8%. And you can see at the baseline of the initiation of this study, only about 65.8% were initiated on insulin. And 1 year later, you can see that number had actually dropped. For those who required to be intensified, the number had actually dropped. And 2 years later, you can actually see still a very high percentage of individuals who required intensification. Only about 58% got the intensification. What we can also appreciate is that initially the initial dose of insulin was 0.64 international units per kilogram body weight. So in the first year, there was good intensification. But subsequently, you can see for the next 1 year, majority of the patients plateaued on the insulin dose that they got. As a result, you can see how the HbA1c remained high because there was no intensification of therapy. So that after 2 years on this treatment, most of the patients were still with poor glycemic control. Now, we can also look at the time cost of this clinical inertia. And this table is adapted from a review article in this study listed here. So what happened is the study looked at individuals with varying HbA1cs at baseline, so 7%, 7.5, and 8%. And they looked at the number of oral anti-diabetic medications that the individuals were taking. So those who were on a single oral anti-diabetic agent, it roughly took about 3 years for them to be given an additional anti-diabetic medication. For those who had a HbA1c of 7.5, it took about 2 years. And for those whose HbA1c was 8% or more, it took about 1.6 years. So generally showing a trend that we tend to intensify our patients the higher the HbA1c, but the duration that we wait is a minimum of about 1.5 years, even when it is necessary to do so much earlier. The second group is the ones who are taking oral anti-diabetic agents, who are taking 2 oral anti-diabetic agents. And you can see the duration to intensify took more than 7 years. For those who are on HbA1c above 7, for those who are with HbA1c above 7.5, again, it took more than 7 years. And again, for those who are on HbA1c above 8, it took roughly 7 years for intensification to be done. For those who are taking 3 oral anti-diabetic agents, the guidelines contraindicated the addition of a 4th. So that part of the evaluation was not done. However, it is also good to note that sometimes it's important to initiate insulin early in the therapy of these patients. So in this same study, you can see that generally for those taking 1 anti-diabetic, oral anti-diabetic medication, it took more than 7.1 years for insulin therapy to be introduced. And at that point of intensifying with insulin, the HbA1c was about 8.7%, which is a tad too late to begin. For those taking 2 oral anti-diabetic agents, intensification with insulin took more than 6 years. And for those taking 3 oral anti-diabetic agents, again, it took longer than 6 years. So what we can see from this, that despite these very high HbA1c values, clinicians generally tend to wait up to 6 years before insulin is introduced. So why do we generally tend to wait this long? So barriers to achieving glycemic control generally tend to fuel the inertia. And one of the issues that has generally been hypothesized is the risk of hypoglycemia. So both patients and caregivers worry too much about hypoglycemia to the extent that we would rather have our patients with poor glycemic control and therefore risk the long-term complications rather than intensify for the fear of hypoglycemia. Majority of the times, this fear of hypoglycemia is actually unfounded. Now, the single most important patient and provider barrier to glycemic control is this so-called psychological insulin resistance. So we just resist initiating insulin both as caregivers, and it is also well documented that patients also fear insulin for various reasons that we may not go to within the context of this lecture. So for us to be able to intensify our patients early, we need to overcome this psychological insulin resistance so that providers are enabled to initiate insulin early and not wait for 7 years, as we have seen. And patients are also counseled adequately that insulin is not a terminal treatment that they need to resist at all costs. Now, there's benefit in early intensification of treatment, be it with oral agents or insulin. This landmark study, the UKPDS, demonstrated this. When you looked at the people who are treated by intensive therapy, either insulin or oral antidiabetic agent, versus those who are managed on conventional treatment, which was largely just lifestyle measures, you could see the groups vary differently, and those who are on intensive therapy had a reduction in the endpoints, which were any diabetes-related endpoints in red, in gray is microvascular disease, and in blue is myocardial infarction. Now, these individuals were followed again for 10 years after the cessation of treatment. So this 10 years was non-interventional. So it was found that the benefits were persistent for those who underwent the intensive therapy, though the reductions were a little less, but still quite significant. And this led to the term, the legacy effect with intensive treatment. That benefits are still apparent 10 years after you intensify treatment in individuals with type 2 diabetes. And therefore, this is actually a recommended practice. So now as we move towards the end of the presentation, we have to look at treatment in these patients with type 2 diabetes. And now the approach to the drug choice in the new era, you need to consider these 4 factors. The first one is what is the patient-specific HbA1c target? Because this is not a uniform target for everyone. Individuals who are younger, you generally look for more intensive control. For those who are older, we do less intensive control because of the higher risk of hypoglycemia. Then we look for the best individual therapy, taking comorbidities into consideration. We also want to prioritize. Do we want CVD risk reduction? Is weight an issue? Is hypoglycemia an issue? Can the patient afford the treatment? And what's the durability of the treatment? And then the last point is that we need to consider the drug class that has the best evidence for safety and long-term efficacy. We know that if we do not manage our diabetics well, then we risk reducing their life expectancy. So in individuals with no diabetes, they generally tend to live their lifespan fully. Those who have diabetes, their lifespan is shortened by approximately 6 years. Cardiovascular disease is the biggest complication and the largest cause of morbidity and mortality in people with diabetes. So a combination of diabetes, myocardial infarction or stroke subtracts another 6 years from the lifespan of diabetics. So indeed, it is important that we intensify treatment, initiate and intensify treatment early so that we avoid these risks of a shortened lifespan. So how do we do this? Now, the guidelines that we use locally have been adapted from international guidelines, the ADA and ESD consensus guidelines. And so there's an algorithm depending on the type of patient that you have. So if you have a patient with an established atherosclerotic cardiovascular disease or has chronic kidney disease, so these are patients who either have myocardial infarction, have had a stroke, or peripheral arterial disease. Then if the atherosclerotic cardiovascular disease is predominant, then your choices are highlighted to the left. A GLP-1 or an SGLT2 with proven cardiovascular disease benefits are the initial drugs of choice. And then if the HbA1c remains above target, then you can add these other options, which includes all the other oral anti-diabetic agents. There's a basal insulin, which you can also initiate as additional therapy. The guidelines do not say which one, so this list does not mean the order in which you must add them. It's just a nominal list, so you can pick from any of these to add to the first two. If heart failure or chronic kidney disease is the dominant phenotype, then SGLT2s with evidence of reducing heart failure are preferred as initial therapy. And then the additional drugs are as listed below. Again, no preference in the order of listing. You can pick any from this list. The second consideration is in people without established atherosclerotic cardiovascular disease or CKD, then we talked about the risk of hypoglycemia. So if you probably have an older individual who is at higher risk of hypoglycemia, or an individual who for some reason may have challenges with feeding, then we pick the options that will give us less risk of hypoglycemia. And so the lists are, you can start with any of the top ones on the list, and then if you do not achieve target, then you can add subsequently. And every time keeping in mind that the additional oral antidiabetic drug should be a low risk for hypoglycemia. And that is the list that we see. So generally it's whichever one you start with, the additional ones will be either of these. Again, no preference in what to start, depends on the nature of the individual you have before you and the cost of the treatment. So the third component that we need to consider is the weight of the individual. We know generally some anti-diabetic medications are associated with weight gain. So initially, if you're starting off with a patient who has a high weight, then you want to avoid some medications, particularly the sulfonylureas, because they are associated with weight gain. So GLP-1s or SGLT2s generally have been shown to be either weight neutral or actually help in reduction of weight. So that is why they are considered first choice when weight is a consideration. Then subsequently, if HbA1c is still above target after using these medications, intensification should be with an SGLT2 if you started with a GLP-1, or a GLP-1 if you started with a SGLT2. If still above target, then the other options are here, including DPP-4s. You can see that sulfonylureas and the glitazones and the basal insulin are a bit lower on the list when it comes to weight consideration. The last and very important consideration is that of cost. This is usually an overriding theme because most of our patients usually have comorbidity. So you will not generally find someone who only requires treatment for diabetes. So people who require treatment for diabetes often require treatment for hypertension, chronic kidney disease, hypercholesterolemia. And this leads to a very high pill burden, which makes cost of treatment quite high. So you need to make a consideration for cost, and usually the cheaper oral antidiabetic agents tend to be the sulfonylureas or the glitazones. And so this one become preference where cost is a major issue at consideration. And then the additional drugs will depend on which ones you have initiated. I think a common occurring theme is that insulin therapy usually remains an option whenever your HbA1c is above target, in individuals with type 2 diabetes. And ladies and gentlemen, I beg to end the presentation there so that we allow the third presenter also to tell us about insulin treatment. Thank you very much.
Thank you so much, Dr. Ndede, and also for keeping time. I believe as Dr. Wanjiru is, you can stop sharing so that Dr. Wanjiru can share her slides. So thank you so much for giving us especially a very good perspective into patient inertia. I'm sure everybody here will now know when to start the patient and the individualized treatment for each and every one of their patients. So thank you so much for that. The next speaker is Dr. Rosemary Wanjiru. She's a consultant endocrinologist, and she'll be speaking to us about basal insulin intensification and initiation. So Dr. Wanjiru, the floor is now yours. Welcome.
Okay. Thank you very much, and excellent presentations to Dr. Lucy Mungai and Dr. Kevin Ndede. Very difficult topics to do in such a short time, but you've done them justice. So thank you also Sanofi for inviting me to talk about basal insulin initiation and intensification. So Dr. Ndede has done quite a good preamble for my talk, and I'm not going to repeat most of what he's done. And as he's told us that type 2 diabetes is a progressive disease, therefore, if patients live long enough with type 2 diabetes, they eventually usually require insulin. And by the time we're diagnosing our patients, they have lost about 50% of their remaining beta cell, and it deteriorates. Therefore, you find that the patient requires the insulin faster than we usually think they would. So who requires insulin? And insulin is usually given to patients who have not reached their target HbA1c, as Dr. Ndede has recommended, and who are on optimum tolerated doses of 3 oral hypoglycemic agents. Please do not go ahead and add a 4th because it will not add value, but will just increase the risk factors. If your HbA1c at initial diagnosis is more than 10%, it is advised to start off with insulin so that even the glucotoxicity can reduce, and these patients are have a chance of being put on orals after optimizing their HbA1c. If your patient presents with features of insulin deficiency, that is, they present with polyuria, polydipsia, and unintentional weight loss, or they have been admitted with diabetic ketoacidosis or hyposmolar hyperglycemia syndrome, it usually suggests that the patient does not have enough insulin, and these are patients you straight away put them on insulin. If at initial presentation their random blood sugar is very high, that is more than 16.7, it is usually advised to start with insulin. Then later on you can try if they can work on orals. For steroid-induced hyperglycemia, treatment is usually insulin or hyperglycemia secondary to pancreatitis, because the pancreas is the one that has beta cells that produce insulin. Therefore, if it is damaged, giving oral hypoglycemic agents will not be of added value. So these are the classes. Not only this, there are many other people, but these are usually mostly absolute indications for patients who require insulin. Now, when we're starting insulin, it's usually a big challenge when initiating, because you have to choose which insulin is available and which insulin will work best for the patient. So the key thing is that you have to individualize your therapy, and patient A cannot be treated like patient B or patient C. So the main things you have to look at is that you have to consider the lifestyle needs. Most of us are in the medical profession. You cannot be treated like who maybe are staying at home and can have regular meals. So you have to look at that patient and individualize. Look at the physical and mental capabilities. Patient who is blind, patient who is dependent on others for their insulin cannot be treated as someone who has all their physical capabilities. Their mental capabilities, someone who's not understanding how you're going to give the insulin, you cannot give them a complex regimen vis-a-vis someone who has all the mental capabilities. Then you have to match the body's physiological requirements treating a type 1 diabetic like a type 2 is you cannot do that. You have to look at the body's physiological requirements and give them the right insulin. So the key thing when you're starting insulin is that you have to individualize and give the appropriate treatment per patient. Dr. Ndede has already gone through this, looking at the barriers, and we have patient-related and clinician-related, and I will skip this. But the key thing is that you have to explain to the patient, you have to show the patient, do not use insulin as a threat. Do not tell your patients that if you do not use your orals well, that I'll put you in insulin, because that makes the patient feel a sense of failure. You also have to educate your patient about hypoglycemia, so that they're not fearful. And also do not tell your patient that next time if you come, we're going to start you on insulin, because that's part of the clinical inertia that causes us to delay starting the patient on insulin. And we have to create time and include a clinic or where we have diabetes educators, we have nutritionists, because sometimes we have very busy schedules and we do not have time, and those are barriers that lead to delayed insulin initiation. And as we have been told, when we do not treat, it is not the diabetes that kills the patient, it is usually the complications that kill the patient. So we have to give them timely management. When we're starting insulin, we have to look at what are our glycemic targets. Again, key thing is that you have to individualize, not one shoe fits all. HbA1c for majority of the patient, our target should be less than 7%, but again, individualize. You're not going to treat a young type 1 diabetic like an old frail diabetic, or a patient who has cancer and other comorbidities and their lifespan is reduced. You're not going to have stringent measures like a young, newly diagnosed diabetic. Then you look at your preprandial capillary glucose and your peak postprandial. Again, also this we try to individualize, but our target is preprandial should be between 4.4 to 7.2, and our peak postprandial, that is after meals, should be less than 10. Now, what are the stages of insulin therapy? Those are 3 main stages. You need to initiate. When you see your patient and you decide that this patient requires insulin, you start on that day. And after you start the insulin, then you need to optimize that dose, because you start at a low dose to reduce the risk of hypoglycemia. You start and build up. And after that, after optimizing, then you intensify. When you intensify, then you get to your target. And before we go to now how we start the insulin, it is important to know what is our insulin physiology. And Dr. Mungai went through this very well. And I'm not going to repeat much, but because the main topic is based on insulin and intensification, what we need to know is that the pancreas usually produces about 40 to 50% of the insulin as basal insulin. What that means is that basal insulin is produced even in our fasting state. It is always there, and it suppresses catabolism of your muscle, fat, and other body tissues when you're not eating. Then the rest of the insulin, that is between 50 to 60%, is produced after we have a meal. Therefore, when you have an increase in blood glucose, your insulin is released. That insulin then binds to your liver cells and activates your glycogen synthase. Therefore, you're able to remove that insulin from the blood. It also activates your adipocytes, that is your fat cells, and your muscle cells. Therefore, the glucose is able to move and you have increased glucose uptake. Therefore, it is a very complex balance between when you lack your insulin, and this is what she explained, that when you lack your insulin, then you're not able to uptake your sugar. Therefore, your sugar is lost through the kidneys. So the other thing is that when our sugar goes down, then the body releases glucagon, and glucagon now breaks down your glycogen so that it can release glucose into the cell. So when we're using our insulin, we need to try and give this, achieve this homeostasis where we reduce the risk of hypoglycemia while controlling hyperglycemia. And when we're initiating there are many guidelines. The AAC, ADA, those are American, and the European study of diabetes recommend that when you're initiating insulin, it is best to initiate with a basal insulin. And what we mean by basal insulin is that a basal insulin ideally should be long acting and should not have a peak. And the key recommendation is that you need to fix your fasting fast, because 80% of your hyperglycemia is usually contributed by the fasting insulin. And once your fasting insulin is fixed, then your liver cells are able to rest, and you find that it is easier to manage your postprandial. If you do not fix your fasting fast, then even your postprandial glucose is very difficult to manage. So the guidelines is that you fix your fasting fast. And when we treat with basal insulin, the sugar that we usually look at is the fasting sugar. So once you initiate your insulin and you optimize the dose, once your fasting blood sugar is optimum, then increasing the dose of your fasting blood sugar just leads to what we call over-basalization and is of no added value. So insulin therapy is usually initiated with a basal insulin so that you're able to supplement the patient's remaining endogenous insulin supply. And with your basal insulin, you reduce your glucose toxicity in the beta cells, and primarily you normalize your fasting blood glucose, and that helps to preserve your beta cell function, so that when these patients present with very high blood sugars initially, and you give them insulin and reduce your glucotoxicity, then you're able to come back and maybe give them orals for much later on the beta cells being worn down and requiring insulin. So the first thing is basal insulin. So this, I just wrote a small case which will just try and show us what we need to do. A 46-year-old male who presented with polyuria, polydipsia, and an intentional weight loss of 18 kilograms over the last 2 months. He has a strong family history of diabetes. He has a random blood sugar of 28 millimoles. What is the next step? So in such a patient, you can already see that he already has features of insulin deficiency. They have polyuria, polydipsia, and unintentional weight loss, and he has a very high blood sugar, so he has glucotoxicity. So in this patient, it is best to start with insulin. And if he's scared of the insulin, you need to show him how the pens look like, or how the new vials look like, and the new insulin syringes look like. They're very small. And you need to show the patient inject the insulin when they're there with you, so that they reduce the fear. This is a patient who you can start on basal insulin and oral medications at the same time. So which basal insulin? The key basal insulins that we use are glargine and detemir. And glargine has no distinct peak and has an onset of action within 2 to 4 hours. And has a duration of action of 20 to 24 hours. Therefore, you can give the patient an OD dose. Before, we used to be told that you have to give it in the evening, but we have noticed that at the same time, even if it's in the morning, provided the patient